Good evening. Welcome to London Valves. It's been a beautiful day. We've already seen some extraordinary sessions in imaging and innovation, and I think tonight will be equally provocative as we have several outstanding speakers that will deal with a variety of issues that begin with epidemiology, evidence-based medicine, socioeconomics, the practical clinical application of new transcatheter technologies, and then a fascinating concluding lecture on technology. So there's a lot to talk about, and we're very excited. And with that, I want to turn it over to our co-chairman, Stefan Windecker, who will give you an introduction.
Thank you, Marty. Good evening, ladies and gentlemen. It's a pleasure to welcome you to this evening symposium sponsored by Edwards Lifesciences. And the first housekeeping I want you to be alerted to is that you please download the PCR app in order to do two things. First, be interactive using the React feature. And please also, at the end of the symposium, vote on the survey which will be available electronically on the app when you have downloaded it. With this being said, it's my pleasure to give you a short introduction, and I think there is no doubt that valvular heart disease is a true public health issue, particularly in the elderly population, where in the population more than 75 years of age, nearly 15% of the general population has significant valve disease. And importantly, this valvular heart disease directly impacts survival and impairs prognosis. Now, why do we discuss transcatheter therapies for all valves? Because as compared to surgery, we have learned during the past decade that this less invasive strategy is not only associated with a 20% relative risk reduction in terms of mortality if you compare transfemoral TAVI versus surgery, but very important other benefits by reducing atrial fibrillation, major bleeding, and renal failure in the order to 40 to 50%. Now, if we look at interventions on the aortic valve level, then truly during the past decade, there has been an enormous innovation, and we have a wide range of devices available with features that allow for a very reproducible procedure. But it's not also only innovation, it's also the evidence which has been generated and actually has directly influenced. Here you see the most recent set of guidelines of the European Society of Cardiology, where now in patients at increased risk, TAVI is on par with surgery and actually is favored in elderly patients suitable for transfemoral access. And an important change in the guideline is that the previous classification in extreme, high, intermediate, and low-risk patients has been facilitated, that we only distinguish between low and patients at increased risk, and that in all patients at increased risk, there should be a discussion within the heart team, but importantly, TAVI favored over surgery in elderly patients. Now, if we move to the mitral valve, then certainly the disease is more complicated, and therefore I think we also need to get used to use a more surgical thinking and approach about the underlying pathology. And as you know, the Carpentier rules, they identify various valve lesions, and we need to distinguish between primary MR and secondary mitral regurgitation. And as a direct result, whereas we have one technique, transcatheter aortic valve implantation, as it relates to the treatment of aortic valve stenosis, the interventional treatment of the mitral valve is much more complex, and certainly we need more than one tool at hand in order to address this issue. Now, as it relates to valvular heart disease, there are still many unmet needs, and it relates to any valve, the aortic valve, where we explore expanding clinical indications, the mitral valve, where we explore expanding indications as it relates to primary MR, but we still need to establish the role of secondary MR versus medical therapy. And as it relates to tricuspid valve interventions, we are in early stage to learn more about the safety and efficacy of a wide range of therapies. And as it relates to this symposium sponsored by Edwards Lifesciences, I just want to highlight that for the every valve, there is a wide range of various therapies available, which facilitates whatever we need to do in an individual given patient. And with this introduction, I just want to highlight the session objectives which we like to achieve in this upcoming interesting program, and that is to learn about the innovation pipeline for the aortic, mitral, tricuspid, and pulmonary valve provided by the sponsor of this symposium, to understand the latest and upcoming evidence in the aortic field, and to learn, importantly, about the economic consequences of innovative technologies. Thank you very much.
With that wonderful introduction, we're going to move to our first speaker, and it's entirely appropriate that Bernard Prendergast be the first speaker at this important main arena symposium. And Bernard will talk about the aortic valve, the standard of care for intermediate, high-risk, and inoperable patients, expanded indication studies underway.
Thank you, Marty. Thank you, Stefan, and thank you to you all for coming to London for this landmark meeting. The explosion of percutaneous valve intervention has been extraordinary in its speed, scale, and scope, and has been driven by a triad of important underlying principles. Firstly, a profound unmet clinical need, particularly in the context of an aging population, pioneering advances in biotechnology and medical engineering, and, as we shall focus in this talk, on an unprecedented body of accumulated and emerging clinical evidence. The unmet clinical need has already been addressed by Stefan, but is also demonstrated in this study, which we led in Oxford and published last year in the European Heart Journal, outlining in red the amount of undiagnosed valvular heart disease in community populations, and looking forward, the projected increase in the both diagnosed and undiagnosed, and thereby the total accumulation of valvular heart disease over the forthcoming 3 decades. The amount of valvular heart disease is going to double in developed populations by 2046. We also have an unparalleled and accelerated pipeline of development with new technologies and new devices emerging on an almost annual basis, and in the last decade have been overwhelmed by an accumulating body of Class 1 Level A randomized controlled trial evidence underpinning our current practice, and the new liberal guidelines from the European Society and the American colleges supporting the continued growth and expansion of percutaneous valve intervention, particularly in the aortic position. We need to bear in mind, however, particularly whilst we are here in London, that we need to mind the evidence gap. And whilst we are unbridled enthusiasts for the continued growth, particularly of transcatheter aortic valve implantation, we need to bear in mind that evidence is yet to accumulate. And my task is to address some forthcoming studies which I believe will be fundamentally important in continuing to change the clinical paradigm. These are summarized in global entity here in this slide summarizing recent and ongoing trials. And the first trial I want to talk to you about, with brief overview, is the Partner 3 trial, which will be going beyond our accumulated evidence in Partners 1 and 2 to look at the elusive domain of surgery and the role of transcatheter aortic valve intervention in low-risk patients. This study, which will follow the model of previous partner trials, will randomize patients on a 1-to-1 basis, those who have already been assessed as low risk by a heart team and with an STS score of less than 4. These patients will be broadly randomized between transfemoral TAVI and surgical aortic valve replacement using a bioprosthetic valve. And the outcomes will be followed over conventional clinical time points, but importantly also with longer-term CT surveillance to answer the elusive question concerning the issue of valve durability, which is going to be an Achilles heel question in relation to the utility of percutaneous technology in these younger, lower risk patients. Within this trial, there will be embedded important measures of quality of life and activity affecting these patients who, despite their low-risk category, will still be relatively elderly. And as we will highlight in the spotlight session at this meeting tomorrow, the advent and growing importance of patient-related endpoints and patient-reported outcomes are going to be an important topic for the next decade. And these issues will be partly addressed by the sub-study addressing these issues within Partner 3. There is also a sub-segment which will be analysing the growing importance of valve-in-valve intervention, which also received strong support within the European guidelines published and publicised at the European Congress in Barcelona only within the last 3 to 4 weeks. Looking beyond the convention of randomized controlled trials for patients with symptomatic aortic stenosis, we also recognize that earlier valve intervention is potentially of great benefit to our patients, particularly when a same-day or 24-hour stay in hospital to achieve effective relief of your aortic stenosis by means of a procedure performed via the femoral artery under local anesthesia becomes available. This disruptive step forward has potential to completely change the paradigm of aortic stenosis and encourage a preemptive approach to management. And this hypothesis and this strategy will be analyzed in the early TAVI or TAVR trial, which will also be conducted within the TVT CRF portfolio. Another important clinical dilemma is the issue of moderate aortic stenosis in patients with pre-existing left ventricular impairment. And the clinically plausible hypothesis that relief of afterload by diminishing or taking away the aortic valve gradient will have a measurable impact on the outlook, the prognosis, and the quality of life of these patients with poorly controlled heart failure. And in this trial, which will be co-led by Nicolas van Meehem in the Netherlands, this hypothesis will be investigated by means of randomization between TAVI in conjunction with optimal medical therapy versus an arm of optimal medical therapy alone. And finally, addressing some of the topics that will be raised by colleagues from Leiden in the Netherlands and covered in a video that will be shown within this symposium, there is also an ongoing study led by David Wood and John Webb in Vancouver, looking at the feasibility of next-day discharge and the ultra-facilitation of the TAVI procedure to allow it to become even more simplified, even more patient-friendly, and arguably even more economically effective. So looking forward, we already have a large body of evidence which is in the early planning, the early execution, and the early recruitment phase, which has the potential to challenge the guidelines produced by the ESC and the EACTS, to further liberate the applications of TAVI and the indications for TAVI, and potentially will argue for a more rapid appraisal of the guideline process and the emerging evidence, rather than waiting another 5 years for the next round of official guideline recommendations from authorities and governing bodies both sides of the Atlantic. It's my projection, and I suspect it's the projection of the majority of people in this room, that TAVI is going to emerge as a clear winner in comparison with surgical aortic valve replacement in virtually all patient subgroups. TAVI is a no-brainer winner, and I would put it to you all that the times for surgical aortic valve replacement are almost over, and the writing is very firmly on the wall. Thank you very much indeed.
Bernard, thank you very much. That was, as usual, it was brilliant, provocative, and I enjoyed your prediction at the end, which is fascinating. So I have to challenge you on that prediction and ask you, where are we with the one area that we really haven't covered in many of these important evidence-based trials, which is bicuspid aortic valve disease?
Okay. Well, this is clearly a very important issue, Marty. We recognize that bicuspid aortic valve is common in younger patients. And clearly, as we step forwards into the low-risk patient subgroup, bicuspid aortic valves are going to be much more widely represented. We also recognize from the experiences of our colleagues in China, Japan, and mainland Asia that bicuspid aortic valve disease may be even more frequent in these populations, where there are vast numbers of patients who have potential derived benefit from TAVI. So bicuspid aortic valve is going to be an engineering challenge. In fact, it was one of the main topics during the Innovators Day program this afternoon, alongside TAVI for pure aortic regurgitation. The consensus seemed to be that we have some engineering steps yet to take, that probably adaptation of current devices is going to be the way to go, rather than reaching back to the original paradigm and asking our engineering colleagues to think afresh. But I think the evidence is yet to accumulate. We're going to need sub-studies of bicuspid aortic valve disease within the ongoing planned and as yet unplanned trials. And I think it is as yet a space that we need to observe. I would also add that we need to remember that aortopathy is a frequent accompaniment of bicuspid aortic valve disease, and it may well be that there will be some subsets of patients with very extensive ascending aortic disease where surgery may continue to play a role.
Bernard, you mentioned the new trials coming up, exploring new indications, and I want to start with low-risk patients, get your opinion and maybe also the opinion on the panel. So the discussion is a little bit what constitutes a low-risk patient, and the definition is an STS score of less than 4. Yet if we look at the trials in the past, in extreme risk, high risk, and intermediate risk patients, really the mean age has not changed much, although we explored lower STS scores. So my question is a little bit, do we truly explore now low-risk patients in terms of age, that is, let's say, patients anywhere between 65 and 75, or will this be another trial where we look at 80 octogenarians that just have a low STS score? And related question is, what do you think is the most important endpoint to look at? You showed the composite of death and stroke, but interestingly, we also have now repeat rehospitalization. From a patient perspective, what do you think in this low-risk cohort is the most important aspect to look at?
Okay, so I think I would reflect on that, and I would say that another trial looking at octogenarians with aortic stenosis is potentially not going to be terribly clinically useful. And Marty may be able to comment regarding the study design, but it was of interest within the new European guidelines that the age threshold for beginning to have the debate around the pros and cons of SAVR versus TAVI is now stipulated at 75 years, and that would be a major change compared with practice certainly in many countries in Europe. Marty, I think you wanted to make a comment.
I can tell you I can't reveal too much data about Partner 3. I can say a few things. First, even though it was an STS score as originally written of 4 or below, when the FDA approved intermediate risk, they allowed us to treat patients commercially with an STS score of 3 or above. So it is likely, as you can imagine, that most of the patients between 3 and 4 would be treated commercially. So I can assure you of two things. I can assure you that we will break the STS 3 barrier, so the STS score will certainly be less than 3, both mean and median, and we will definitely break the 80-year-old barrier.
That's
and
very
you could imagine that these
hear.
Patients will be obviously in their 70s.
Can I just add that also there is the ongoing Notion 2 trial, which is being led by colleagues in the Nordic countries, and the enrollment for that study is going to specifically enroll patients at a much younger age and will address some of these issues. And with regard to endpoints, Stefan, for me, the most important solid endpoint that's going to come out of these studies is the long-term follow-up and the answer to the question regarding durability. Because of course the dropout rate in octogenarians who are followed up over a 10-year interval is substantial. But by randomizing younger patients and by following them up systematically with clinical, echocardiographic and CT variables is going to be fundamentally important in advancing the science.
I mean, if we regressed and went back to the original series of trials where the major endpoint was all-cause mortality, to do a low-risk study would involve 10,000 patients. So we needed to broaden that, but we did pick endpoints that have been clearly associated both with one-year mortality and with declining quality of life as measured objectively. So the idea of including strokes and repeat hospitalization for heart failure or valve-related causes we think are relevant to patients, which is why that endpoint was chosen. I'd also like to add that the other trials that Bernard beautifully explained are not virtual trials. These trials are now ongoing. So we are enrolling patients in the early TAVR or TAVI trial, and we are enrolling patients in the UNLOAD trial, which is wonderful because it really is it is Canada, Europe, and the United States. So I think we have an opportunity to ask and answer some new questions that would raise some provocative notions about who we might be treating in the future.
And Marty, can I make one comment? You said we don't need a surgeon anymore. Being a surgeon here. No, you didn't say that, but Bernard said. I think the way to go is side by side. Because what happens if you get into trouble and you get a surgeon who has never done or only has done a few procedures? And of course, the redo procedures are very complex, even getting out of TAVR.
So I think maybe, I can't remember what my specific words were, but I'm not sure that open sternotomy to replace the aortic valve is going to be necessary in many patients in the longer term. Whether it's hybrid surgeons, whether it's hybrid interventionists, whatever terminology you wish to choose, who does the procedure in 10, 20 years' time is a completely different discussion.
I agree.
Well, thank you very much, Bernard, for this exciting outlook, and I would say that the new guidelines really emphasize this heart team approach, so I think it should be in common way. And it's now my pleasure to transition to another important topic and to invite Miles Ayling, who will touch upon what is the value of innovation in less invasive procedures to patients and healthcare systems.
Thank you, Stefan, and good evening, everybody. I'm going to talk a little bit about the value of innovation and why it's ignored by many, what this problem is about trying to mainstream innovations, whether it's technologies, medicines, or devices. And I stress that I come at this from a bureaucrat's perspective. I spent 30 years working in the Department of Health and the NHS, most recently as the National Director for Innovation. Left a couple of years ago, been working with Edwards since then to help them try and understand the NHS, what influences its decision-making, and why the adoption curve is so slow. So we'll start with how a payor values innovation. None of this is particularly difficult. It'll be known to you. You'll all probably understand this far more than I do, and it's pretty obvious. You know, you look at balancing the cost against improved outcomes and patient experience, don't you? In this country, we have nice gold standard health technology assessments. You've got QALYs. You can make it more sophisticated with actuarial or health economic data. And you would imagine there's a premium for reduction in utility elsewhere in the system, and also a premium for reduction in preventable recurrent events in future years. That all seems to make sense. And the reason for doing that's as obvious as well. You save lives, you save money, you save time, you improve patient outcomes, you improve patient experience. If we didn't innovate, we'd still be operating with saws rather than lasers, wouldn't we? So why are high-cost devices particularly being overlooked by the NHS, but by other health economies globally? One of the main reasons is they're often seen as non-essential by bureaucrats, people like me. It's a nice to have, but people see it as part of the problem, not the solution. And I joined NHS England when it was first being established a couple of years ago. And one of the first challenges it faced were new Hep C medicines and TAVI. And the conversation wasn't, these are game-changing, these are going to deliver fantastic improvements in the quality of care for patients. The conversation was, we can't afford that. It's going to bankrupt us. How do we engage industry so we can try and drive down prices? And affordability and cost effectiveness are very different things. Often when I used to speak to people from industry or clinicians, they'd say, you've been through a nice assessment of cost effectiveness, therefore it makes sense to use this particular technology. But if you haven't got the money, particularly the cash flow, the in-year cash flow, to pay for those technologies, it doesn't matter how good they are, you won't be able to buy them. Now, clearly, there's a risk that organisations like NICE are going to be undermined if they produce a recommendation and it's largely ignored by the NHS because they're not able to afford it. And it could lead, and there's a real risk with this, it could lead to a race to the bottom, where health economies, the key decision makers in health economies, are just concerned about the lowest cost product, the lowest cost technology, irrespective of patient outcomes, irrespective of how good that product might be, and irrespective of the economic or actuarial data that says you'll suppress long-term health costs if you invest in the short term. But if you look at the NHS, you'd argue they've got £130 billion worth of funding a year. They're swimming in cash. They just need to refocus, don't they? Well, it's not that simple, particularly if you're an organisation that's in financial distress, as most big hospitals in this country are. You operate on a week-to-week basis. So if somebody from industry coming along and saying, here's a fantastic new product, it has got a premium in the price, but the outcomes are fantastic, you'll start to save significant sums of money in years 2, 3, 4, 5. It's too late. They're operating on almost a hand-to-mouth basis, week to week. They won't be around in a year or two's time unless they get hold of their finances. So that influences their decision-making. And finance dominates all, even over patient outcomes. And when I joined NHS England, one of the reasons I joined, because there was a very clear statement by the chief executive at the time, David Nicholson, that it was going to be a clinically led organisation. Decisions taken at a board level would be clinically driven. If you look where NHS England is now, that's changed quite significantly, and you have policy officials in the lead taking largely financial decisions about the long-term affordability of healthcare. So, you can no longer rely solely on a positive HTA or an MTB. You can no longer rely solely on some of the fantastic evidence that Bernard mentioned. The job of clinicians doesn't end with the publication of study results. It's more complicated than that now. But there are things that you can do. First one is don't ever underestimate the influence of clinicians, even in the most financially distressed systems. Even if directors of finance are the ones that are taking most of the decisions, clinicians have enormous influence, locally, regionally, nationally, whether it's with politicians, whether it's with the media, whether it's with patient groups, whether it's... I'll start again, sorry. So, yeah, don't underestimate the influence of clinicians, even in the most financially distressed systems. The right way of describing this is they have a huge amount of influence at the very other end of the spectrum. Healthcare managers need to have clinicians on board. They need your support. They can't run the NHS by themselves. So if there's a groundswell of opinion about new innovation, about a new technology, managers will listen at a national and a local level. Politicians will listen. Learn to speak the right language. It's interesting, Bernard mentioned unmet need. As a bureaucrat, when I heard people talk about unmet need, I thought unmet cost. So it's important that you talk the right language or you'll never find the right compromise to get new technologies that have got a premium adopted. Act collectively as clinicians. Again, one of the things that politicians and senior managers love is when clinicians can't agree between themselves what the right thing to do is, because it means they don't have to make a decision. They'll just say, well, you guys can't decide, why should I? When clinicians act collectively, it's very, very difficult for them to ignore that, and it's very difficult for them not to make a decision. A good example of that in the UK is VTE. Huge problems with that going back a number of decades. Clinicians, the media, and patient representative bodies created a real momentum for change, and despite the fact that change cost significant sums of money, introduced new risk assessments in hospitals for all patients, it was introduced very, very quickly. And we saw an improvement in hospital VTE in a year that was greater than the improvements that had been made in the previous 10. So working collectively can make a difference and can influence. Act collaboratively with industry. A lot of clinicians often feel nervous or reluctant to work with industry, but that too can deliver real benefits and accelerate adoption. There's a piece of work happening in the UK at the moment around NSTEMI, where industry has funded a post for a senior clinician to work with his peers around the country to try and raise awareness, try and build advocacy for NSTEMI patients. And to quote the industry rep who's leading on that work, everywhere that individual goes turns to gold, because it's not industry going and trying to sell a product, it's a clinician going and trying to advocate for a change in clinical practice. Work with the charitable sector as well. They have real influence. One of the quickest changes in policy I saw when I was with the NHS was the Cancer Drugs Fund, when there was a suggestion that the cancer drugs funds might be scrapped. And the chief executive of Cancer Research UK picked up the phone, rang the Secretary of State and said, "You've got an hour before I go to the media with a press release." And within an hour, that policy was changed. It never made the media. And that wasn't because necessarily of that individual's influence or Cancer Research UK's influence. It was because of the implications of that becoming a headline, an unwanted headline. And finally, help develop and promote better real-world evidence. Study evidence is fantastic, trial evidence is fantastic, real-world evidence really matters. Being able to demonstrate to people that some of those results that you saw in trials can be translated into everyday practice in the NHS. And a good example of that is novel anticoagulants in this country. Huge amount of work was done to build clinical advocacy, to try and raise profile and awareness, to build the real-world evidence, supporting the use of NOACs. And although, in comparative terms, the utility of NOACs is still lower than it is in some European countries, it's increased by a factor of 5 in this country over the last few years. So in terms of resetting that balance, trying to get to a point where clinical decision-making is as important as financial decision-making, what are the key takeaway messages? Well, decision-making should be clinically led, but that's only going to happen if you make it happen, if clinicians make it happen. You can no longer just rely on that research data. You have to continue to push hard, even if it's down just to nuisance value, and that work collectively to try and get decisions made. Don't underestimate the difficulty in doing this or your influence with the media, with politicians. It won't happen overnight. But you must act collectively. It may take years. The examples I've just given did. Things can happen just as quickly. Healthcare-acquired infection, the improvements in that were startling and achieved over a 12 to 18-month period in this country. Fourth, it needs action from the top down and bottom up. So you've got to build advocacy at a very local level, individual hospitals with individual clinicians. But at the same time, you need to make sure you've got the support and endorsement for these premium products at a national level with government, with ministers, with very senior bureaucrats. And it's only when you get those two, when you get them in balance, that you see change happen quickly. Data, real-world evidence, critically important. Whatever you can do to develop that, share that with people in healthcare systems, the easier it will become to persuade them that these sorts of technologies do deliver improvements in healthcare and are affordable, rather than people just seeing them as a cost. And finally, be open to new collaborations. I think the days of the public sector and the private sector being very separate, certainly in this country, are over. Simply doesn't make sense that manufacturers and customers don't work together collaboratively. It doesn't make sense that clinicians aren't involved in that process as well. Certainly the evidence emerging from a number of recent projects that I've seen or been involved with is that it does deliver change and does deliver change quickly. So I'm going to finish there. take any questions from Marty or the panel.
Well, thank you very much. I think it's an important topic, and if there's a remaining major hurdle for implementation of these therapies, it's certainly cost and what regulatory bodies think about it. Maybe I tell you my perception from a clinical point of view. We do clinical trials, we have endpoints, and they are uniform for all physicians on the world. If you have a superiority in terms of, let's say, mortality or stroke or rehospitalization, I think any physician on the globe understands the outcome and wishes to implement it in his practice. Yet if we turn to cost effectiveness, it seems we speak a completely different language because there is different health expenditure from nation to nation. There may be different social values and so on. And my question relates, are there any efforts to develop one common language also as it relates to cost effectiveness in order to save time and make insights as it relates to cost applicable on a global level and not just limited to the United Kingdom or some other individual countries?
It's a good question, Stefan, and I think the real-world evidence is the bridging language. You know, it's not the trial data, it's not the complex balance sheet data that financiers would look at. The real issue, I guess for me, is in health economies where you are restricted in terms of your cash flow. How do you persuade commissioners to invest in technologies that might have a slow return on investment? And part of that argument, I guess, has to be developing a narrative that is compelling both to politicians, to government, and to the media. And TAVI is a really good example that at the moment, the way that access to TAVI has been restricted in this country arguably writes off a whole cohort of patients. And to my mind, that just simply isn't acceptable. But that conversation isn't happening in public. It's certainly not something the media are talking about. It's something that probably a lot of clinicians understand and talk about. It's not a conversation that accountants or directors of finance in the NHS will have. They'll see lots and lots of similar problems and lots of similar areas of unmet need. So I think hopefully real-world evidence will bridge that language gap, but it is a case of developing a narrative that is compelling for politicians, for the media, for senior managers.
Well, first, Miles, thank you very much for a lecture that was comprehensible and simple enough so that the usual health economics, abstruse and marginally understandable lecture you've successfully avoided. So thank you very much for that. But I have a question which is an extension of the question that was asked by one of our members of the audience, who asks, are there any data showing long-term differences between surgery and TAVR? Right now we have 5-year data in randomized trials, but when you look at the health economic assessments, do you also have in your mind a time domain of the effect? And we're talking about procedures that influence patients' lives and the natural history of their disease. How do you factor that in? It's a serious problem for us as we deal with these durability issues, but from a health economic standpoint, how do you deal with it?
Yeah, I'm not a health economist, so I may not be the best person to ask, but I've certainly employed health economists, and the question I would ask them is, where is the long-term, the longitudinal data that demonstrates to me the long-term cost-effectiveness of those procedures? And I've certainly not seen any that goes beyond that 5-year cycle. So I think, to be honest, that there is a huge issue in the NHS, and I think this is the case with a number of health economies about tracking patients over a long period of time, whether it's 5, 10, 15, 20 years, and being able to identify what the impact of some of these sorts of procedures are on their long-term well-being, their long-term health and cost to the NHS. But the simple answer, Marty, from my perspective as a healthcare manager is I've not seen that data, but I have asked for it often.
Well, thank you very much.
Thank you.
So we're going to move on now and have a very interesting presentation that will be given jointly from our colleagues from the Netherlands and Leiden, Arend de Weger and Frank van der Klee. And they're going to talk about their experiences with TAVI optimization with the SAPIEN 3 valve, looking at the course of one day in their laboratories. And hopefully we'll have an opportunity to comment on this and add some further insights. So please, go ahead.
Thank you. Let's see which name is on. I'm not a surgeon. Arend de Weger is a surgeon, but we mix up the team, so this time it's Van der Klee.
No, we're interchangeable.
We are really interchangeable. What we want to discuss is about how we can perform multiple TAVIs in one day, and in this case 7 TAVIs. We don't have disclosures. What we call it is the assembly line. And what we do is we define the different wards where we store the patients. Actually, indeed storing the patients in different spots. So we start first in the cardiology ward or the thoracic surgery ward, where we hospitalize the patients one day before the implant. We just do the preparation of the patient, and then the next day we order them to the specific places where we want to have the patients just before their TAVI. So we put in the IV lines, we put in the arterial lines, then we go to the cath lab. And in this case, in this series of patients, we did general anesthesia, so we intubate the patients, we implanted the TAVI, and then we moved the patient forward to the next storage. And in this case, it's the recovery room, because they had general anesthesia, so the respiration function has to be checked. And after a while, we continue the assembly line and transport them to the coronary care unit, all in the same day. And of course, at the end of the day, we transfer them back to the cardiology or thoracic surgery ward. And why do we do this? Because in this case, we implanted 7 TAVIs in patients. Normally, we plan 5 or 6 cases in a row. So we have to define where can be the bottlenecks. We can hospitalize multiple patients in the general ward. So we start them to hospitalize them there. But the bottleneck is actually in the cath lab and in the short stay. So the cath lab, we can only treat 1 patient at a time. So what we will do is, if we ask the first patient in the cath lab, and they are prepped with the arterial line, the IV lines, we treat the patient. And during the implantation of the first patient, we ask the second patient to come to the short stay, to be prepared already. The normal average procedure time for a TAVI, from bringing in the cath lab to leaving the cath lab, is between 60 and 75 minutes. So we can store another 2 to 3 patients in the next facility. That's the recovery room, where they check the respiratory and the hemodynamic status of the patients. So if we can store 2 or 3 patients at that time, we can pull them a bit. And generally, you can forward these patients to the next ward, in this case, the coronary care unit. And after 1 or 2 hours, we can forward them back to the general ward. So if you define the bottlenecks in this process, and you make some pulls in your hospital, and in this case, we are challenged by waiting lists of patients and limited the amount of data where we can implant TAVIs under general anesthesia in our hospital, we are challenged to increase the numbers of patients per day. So we started 10 years ago with 3 patients in a row, then we increased to 4, then to 5. So it's normal to start to do 5 cases. And then we have exceptions that we treat 6 patients. And now we have exceptions that we treat 7 patients in a row. So if you define these bottlenecks and you pull them at certain moments in the time period in the hospital, then we can treat all these patients. But of course, you need a team for this. It's not one guy who plays the violin. So we need a team in the cath lab, but also outside. So the nurses in the ward, the nurses in the short stay, in the recovery room, the managers who plan the hospitalization of the patients. And in the end, we can treat all these cases. So I think it's nice to continue with the video.
Welcome to the University Medical Hospital in Leiden. My name is Arend de Weger. I'm a cardiac surgeon. And next to me is Frank van der Klei, he's the interventional cardiologist. And what we would like to show you today is a normal routine day, or TAVI day, in our hospital. We're in Cath Lab 5, and with us is the whole TAVI team for today. Starting with Jeroen Wink, he's the anesthesiologist. Nina Aimone, the cardiac imaging cardiologist. Joost, Ardien, Ilse. We've got Lisbeth, Vanessa, also anesthesiologist, and we've got Vincent. So what we like to show you today is how we came from 2 cases in 2007 to normally 5 or 6 cases today. And this can only be done in a very tight collaboration with the whole team. And this is what we want to show you. So today we want to do 6 cases, maybe more, just to show you how it's done in Leiden and what we think are the best tips and tricks. We did the briefing for the whole team in Dutch, so not to disturb the whole process. And I think what's very important to see is that the whole surgical team and the scrub nurse were all almost ready at the time that the patient is asleep, so that we really can follow up everything very quickly and do everything. And that means that you sometimes have to do things as a surgeon or a cardiologist, which is not in your league. But if you want to really speed up the process, everything has to go into the flow and you have to do everything what you need to do. So what we like to do is to prepare really everything so we're all set to go, and that you don't have to search for instruments or catheters.
Stop deze. Check the position.
Yeah.
Yep.
Okay. Pusher is terug.
Op zich zit hij wel oké, hè?
Ik denk dat hij wel oké zit. Goed, we gaan de klep zo plaatsen.
Oké, is dat goed,
Iedereen
joh?
klaar?
Oké, start deze.
Is het goed, hè?
Oké, blazen maar. Blazen, volle bak. Los. En stop deze. Nice position. Oké.
Okay. So this is a 79-year-old patient with polio in the past, and she has aortic valve stenosis, typically low flow, low gradient, and she has a ischemic CVA,
so in March this year, and that's why we decided to do a TAVI valve. She has got a cyst of her hip on the right side, so that's why we go on the left side this time. So we introduced the valve on the left side. It will be a Sapien 23 again, and well, we're almost ready to start. So Nina has made the echo assessment. It's a very small left ventricle, and as you can appreciate, the valve is calcified. So the mean gradient is 28, but it's a paradoxical low flow, low gradient valve, and that's because of the very small cavity in the left ventricle. What we always try to do is to have as much as echo support as possible. So what you have to do is really talk with each other and say, okay, can you move the probe a little bit up, or can you move the probe a little bit down? And but in lots of cases, I mean, you can work side by side, but it's really close collaboration.
The LV is really small, so I hope the J-guide can make a loop, with the Safari wire can make a loop in the LV. Yeah, if you have a lot of rhythm disturbances, then we have to change the position of the wire. But if it's stable, then we leave it like this. The sheet goes in very smooth. That's the advantage of this this e-sheet. It's coated. You advance it really easily. Also, if you have calcified vessels, it goes in really smooth. Let's dilate the aortic valve. So start pacing. Pressure goes down. A little bit more distal. Yeah, okay, blazen. Release. Los. And stop pacing. Okay. This pacing, we try to keep it as short as possible. Then the patient can recover more easily. So the longer the pacing time, the more problems you will have with recovery after pacing. Well, in the meantime, Ardeen prepared the balloons and the sheets and the valves. So once we have dilated the aortic valve, the valve is already prepared, and we can directly access with the new valve. We check the position of the valve. It's a 23 valve. I prefer to remove the pusher as soon as possible.
Okay.
If you don't forget this.
Pusher is back.
To get the
If you repeat all the steps aloud, then everybody knows where we are.
Start pacing and try the pressures down. Yeah, okay.
Yeah, are we okay?
Klein beetje. Ja. Oké, blazen maar. Door, helemaal door. En los. En stop pacing. Wacht even.
These patients with a kind of horizontal plane are difficult to assess and to place the valve. But I think we were very pleased with the position, Frank.
Yeah, the position looks fine. But
So
let's check whether the valvular, is it a paravalvular or valvular regurgitation. The wire also gives some tension to the leaflets of the Sapien valve.
Yeah.
So we wait for the echo performance. That's why we prefer to have TOE during the procedures, to have an optimal visualization of the valve and to make a correct strategy.
So we saw a very small paravalvular, so the blue one, very, very small. And what we typically see with the Sapien 3 is that will probably diminish in a couple of minutes as well. Okay.
You put it in partially and then retract the sheet over the introducer. Wait, it's fixed. Okay.
What we try to do is to get rid of all the sheets. So once the patient has got sinus rhythm, no new left bundle branch block, then we'll decide to get rid of the venous sheet as well, where the pacemaker is, and we try to do an angio of the groin to see what happened. And you see a very nice result.
Hartstikke idee.
So
Done.
shall we take out the wire? She's got some extras, but
Yeah, she has some blocked atrial extrasystole during the PVCs, but once she has, if she doesn't have any PVCs, then there's normal conduction.
okay.
So let's remove the pacemaker.
Yep. So in the meanwhile, what Frank is doing is he's making the report of the procedure, and anesthesiologists, of course, are preparing the patient to get to the bed. So, and the rest of the staff is preparing for the next case, and that's why we can speed up things a little bit. So this is an 83-year-old man with numerous colon operations because of cancer, and he's got hypertension as well. And we chose for his age and the numerous operations for a transfemoral approach. We will place a 26 valve. And the measuring, the CT measuring, it's a little bit between, so a high 26, low 29, but we choose to do a 26 valve in this case. We will do 2 cc's more in the balloon, just to give it a little bit extra. And we'll see how it's going to work out. So the echo assessment showed us that there's an AR and an MR as well. So we knew that. We've got a very nice echo image of the wire to the mitral valve there.
Remove the pusher again.
Okay, pusher is out.
Let's check the position.
I think it's okay.
Maybe tiny bit up.
Yeah, a little bit up, okay.
Yeah.
So I think what's important when you work together is that it doesn't matter who pushes the balloon, but it's really important that you're both seeing that the position is right. And that you have to agree upon that before.
So we'll test and
advancing.
check the position. Okay, start pacing. Okay. Ja,
I think that's good.
Ja, blazen maar.
Okay.
Blazen door. Volle bak, alles erin. Alles erin en los.
And we're really taking some time to let the balloon
stop
expand as much as possible. So the wire is out
Wires
now.
out. MR is reducing dramatically.
Probably the patient is doing better then.
The blood pressure increases directly. Yeah.
Yeah. So what we usually do is leave it in for 24 hours, and then so tomorrow, when there's no extra disturbances, then we take it out.
Ja hoor, zit erin. Start pacen.
So we have capture. I think it's okay.
Oké, ja, blazen maar. Blazen, volle bak, ja. Alles erin. En los. En stoppezen.
In our team, we have the golden rule that Frank or the other interventional cardiologist, Janis Corrales, gives the commands. And of course, when I think that Frank forgets something or somebody else, I will push him slightly and say, okay, maybe stop rapid pacing. But
Yeah, okay. She sees paravalvular leakage, so she will go to transcatheter recordings to have a better image on the paravalvular leakage.
so maybe we can prepare the syringe with 2 cc's more.
Yeah, if you measure on the CT, she had an area of 440 square millimeters, so it's just borderline 26. We've implanted a 26 valve.
Okay.
So according to the measurements, she would just, on the lower side of 26.
Mm-hmm.
But
Should be okay.
so it shouldn't be necessary to post-dilate with more volume.
Okay.
Shall we remove the wire then?
Mm-hmm.
I'll pull the wire. I'll make an injection just above the valve also. So position is okay, so there's still some regurgitation.
So what we did is we advanced the pigtail through the valve, and we're using the side port of the E-sheet to measure the arterial pressure.
So the end-diastolic pressure is not low. So I think we shouldn't do anything else.
No. Yeah.
Okay, there's a nice difference between the end-diastolic pressure in the left ventricle and the diastolic pressure of the aortic.
Agree.
Okay.
No, I haven't.
Okay, make the final angio. Okay. Sorry.
Perfect.
See some calcified myomas.
So it's again a patient with a low flow, low gradient aortic stenosis, but you see on the echo you can appreciate the spontaneous contrast. So it's
In the atrium.
really low flow.
And no flow, no atrium. Resistance.
It's a little bit tortuous, so that's why
And some resistance.
some resistance. You can appreciate the calcium of the aorta,
Up again.
and this is not what you want to see, but what you often see.
1-to-1.
Okay, yeah. I think it's okay.
Ja, blazen maar. Blazen, volle bak. Zo, alles. En los. En stop pacing. En check de backup. Even wachten.
So the patient was known with chronic or permanent atrial fibrillation, and so this is a little bit brachycardic. The position is excellent, I think. We're a little bit low on the
Right coronary cusp.
yeah.
On the other hand, left and none is correct.
Yeah. So we see some regurg, but we think it's from the wire. Take out the wire.
Up again.
The wire is out
Wire is out.
now. Mm-hmm.
You have an extra view on the iliacs because the sheet flipped in quite abrupt. Ik had nog niks. Right. Common iliac. But that was the reason why she had a little bit of hub at the introduction. But no further dissections visible.
So because of the brachycardia, we're going to leave the pacemaker in. Just discussing about ordering the next patient to the short stay, so which is about 50 meters from here. And when the procedure is ready, then the other anesthesiologist can take the patient to the recovery room, and the next patient, when the room is ready, can be placed on the table. So it's now quarter past 2. So this is the 6th case. We just started a couple of minutes ago. And because we had a backup patient for in case one of the patients posed some problems, we decided to do the 7th patient as well. So the 7th patient is now being prepped. And we're going to continue after implanting this case. So Nina says that we're again bothering the mitral valve with the safari wire. But it's a small ventricular cavity, and this patient was admitted with several times collapse.
Push her back.
Pusher is back. Slightly up.
Okay. Okay, start pacen. Okay. Iets. Ja, langzamer. Ja. Ja, door, volle bak. Alles erin. En los. Even wachten, stoppen met pacen. Well, we saw in this case that she had, during the balloon inflation, she had already a AV block, but she recovered, and now after implanting the valve, she showed a total AV block. So we do some pacing, see what's the result of it after a few minutes, whether she gets her own conduction back or not. So I'll pull the wire then, and hopefully the MR is going to reduce again. Yep, okay. Yep, that's out. So MR is almost gone. And the aortic valve
is trace, huh? Yeah. Okay.
Okay, then we're
going to leave it at that.
Yeah. Okay.
Yeah.
Okay.
So in this case, we will leave the temporary pacemaker wire in. So what you see at this patient has had an EVAR in the past, in 2010, and with 2 short iliac stumps, so to say. The diameter is good, it's 8, so that's no problem. And we had a CT because it's a patient from a referring clinic. And we had a CT, but it was not as conclusive as we wanted. So the plan now is to make a short injection in the aorta and to have an assessment also of the root, so to see if we need to use a 26 or a 29 valve for this patient. So we made a short injection into the root, and together with the echo findings and the bad CT we had, we're going to decide for a 29 valve. So you see it's going very smoothly through.
Hoppakee.
Excellent.
Ja, oké, start pacen.
Ja.
Oké.
Ja.
Ja, blazen maar. Ja, gaan we. Volle bak. Hup. Alles erin vasthouden. En los. En stop pacen. We will remove the sheath on the fluo. See whether we don't dislocate any of the stents. See there's some traction on the system. But it goes smooth, huh?
Mm-hmm.
Okay. Harry?
Yeah. So it's 3:45 now, and we're ready with the 7th case. I think that I hope you can appreciate how it's done in Leiden, and how the collaboration between every field in the hospital is very, very important to get a result like this. So I want to thank the team in Leiden very, very much. Not only the people you've seen in the room, anesthesiologists, nurses, echo, Frank, of course, but also the people you didn't see on the screen from the short stay, from the ward, and hopefully we can show you some patients how they're doing now. Thank you. Zo, hoe gaat het, mevrouw? Gaat het goed?
Ja hoor, gaat nu weer prima. Het gaat nu, ik ben vandaag geopereerd van een TAVI en nu gaat dat gelukkig ook allemaal weer prima.
Zo, mevrouw, hoe gaat het? Hoe gaat het met u?
Heel goed, ik voel me heel fit. Ik zou zo wel uit bed kunnen stappen.
Ja? Heeft u ergens pijn? Of,
Nee, absoluut niet. Nee, echt niet.
Vanavond lekker wat meer op gaan zitten en dan snel gaan mobiliseren. Want hoe sneller u mobiliseert, hoe sneller u weer het ziekenhuis uit bent. Ja?
Dat ben ik ook wel van plan. Ik ben niet zo'n lichter eigenlijk. Elke dag vroeg op.
Mooi zo. Nou,
Heel
goed
goed.
herstellen.
Precies. Oké. Dank u wel.
So that was quite a display, and I think we have a little time now to have perhaps some provocative discussions. Before I ask some of the questions that the audience has been asking, I think the two things that struck me were you have a remarkably orchestrated team. And I love the way the two of you work together as a surgeon and interventionalist. This is what we have tried to encourage. It's not achievable in many environments, is the reality, but certainly you clearly have made that work beautifully. So the orchestration of all the components of the team is striking. But one in particular that struck me was the role of anesthesia. And you had two anesthesiologists assigned. You didn't do any extubation in the lab, so you can extubate them in the recovery area, so you could get them out of the room very, very quickly. And that made a very big difference, I think, in improving the efficiency of the operation. That's the one area that we stumbled with. Our anesthesiologists refuse to take the patient out of the room to extubate them. So it delays every procedure by 30, 45 minutes in terms of the turnover time. You've been able to overcome that and to overstaff. I will say this is not an understaffed operation. You have 8 people, including 2 anesthesiologists, and then the 2 operators, so 10 people doing the procedure. So it's a very well-staffed group. but it was really fascinating to watch. And maybe we can have some other reactions from the panelists. Stefan, Bernard.
Sure. So first, congratulations to do 7 cases a day and be finished at 4 o'clock, starting at 8:25 is remarkable. I must say I share the impression Marty had, and beside all the other orchestrated things, what struck me is the turnover time was really anywhere between 10 and max 20 minutes. And this is truly remarkable. And maybe you wish to comment on this, how you achieve this, because I think this is a very important bottleneck, and whether it is just that you have 2 anesthesia teams, one preparing, intubating, and doing everything else with one patient outside, and the other group taking care of the patient inside. But is there more to it? Because 10, 15 minutes is really short. What about the staff in the room? And can you share some more detailed insights?
Actually, our ward is at the 9th floor, and the cath labs and the OR and the recovery rooms are at the 4th floor. So normally, if you ask for a new patient, it can take you 20 to 30 minutes to bring the patient from floor 9 to floor 4. So we bring them already to floor 4, to the short stay, to get rid of this time delay between the floors. So this gives a time gain. And on the other hand, part of the anesthesiology team is going to the short stay to prep the patient already. So once one anesthesiologist with the nurse is leaving the room with the patient, and they're bringing, on their way back, they're bringing immediately the second patient back in the room. So actually, the anesthesiologist is not drinking coffee in our hospital. Normally, they're drinking coffee and reading papers, but they don't have time to drink coffee.
Save money, maybe the...
Well, one obvious question, and then perhaps we can have some of Bernard's reactions to this. There were several questions on the same theme, which is you were able to do 7 cases and finish by 4 o'clock. You could have done 10 cases if you didn't use general anesthesia, transesophageal echocardiography, and did the majority of these just with conscious sedation. So what is your response to those kinds of reactions?
Of course, we do also conscious sedation or general or local anesthesia as well. But what we see is that the time gain is not that much. The time gain is not that much. So because we have the anesthesiology team is so well equipped and so good that they are able to intubate the patient and extubate the patient as we are proceeding. So that's I'm not sure if it's really a big gain in time. And we like to do the TOE because we want to see what happens. And maybe not that is important in this valve, in the SAPIEN 3, because you seldom see big or paravalvular leakage. But I think with the other valves, it's important to see.
If I can just follow up for 1 second, do you leave the decision up to the anesthesia team regarding local versus orotrachea?
No, we decide, but we also try to do it together. So if we've got difficult patients who are very sick and where you tend to say, well, can we do it in anesthesia, yes or no, then we come back and sit together and talk about these patients together. So the anesthesiologist is really part of the team.
So the key elements here relate to the interprocedural time, don't they? It's all about the turnover between the patients. I mean, you're clearly very slick operators, but you know, TAVI using the commercially available valves now is a fairly reproducible procedure in terms of the time it takes to go from skin to skin. But what you very effectively demonstrated is how you become ultra efficient by having a team around you, make sure that the downtime between the cases is absolutely minimal. And it's interesting, the model with 2 anaesthetists, that's clearly a very good way to go. There are other models in different units where you have 2 cath labs and you can alternate the patient between 2 labs, and you can do it that way. The interesting thing for me is to ask you the question whether you do 6 or 7 cases every day, or whether this is your TAVI day of the week.
Well, that's our TAVI day of the week. Actually, we have scheduled TAVI days every 2 weeks. And we do in between, we do the local anesthesia on the uneven weeks.
Because the major, I don't know what your comments would be, Marty and Stefan, in other high-volume centres, but the other issue for us would be if you're doing 6 or 7 on an almost daily basis, that's a lot of patients for your heart team discussions, there's a lot of CT scans, there's a lot of outpatient clinic appointments, there's a lot of follow-up echocardiograms. The whole workload and the whole work stream is incredibly complex.
And then the bed capacity becomes an issue, because one of the things we learned was one of the delays was having patients ready to go to the coronary care unit. So, and I just wanted to comment, that is a step that we have not completely, but largely eliminated, in that we recover the patient. Now about 2/3 of the patients that we do, we recover them in the recovery area for 4 hours. Then they go to a step-down unit and they avoid the CCU, because you can fill up your CCU very, very quickly with TAVI patients, and that becomes a limiting issue. We also do the vast majority of cases as a same-day admission. So we don't bring them into the hospital beforehand. They come in the morning. They get the blood work done very early, and they're done that day. So there are interesting things you can do also. And as Bernard says, we have a 2-team approach, because we don't have as much flexibility with the anesthesiologist that allows us to make up time. So we're doing these in groups of 2 with 2 different teams of operators.
Maybe one other question relates to the setup. Again, you have a very nice hybrid OR and environment, and you showed us a day full of TAVI. What about other interventions you do, let's say on the mitral valve or other valves? Do you sometimes have mixed days, or do you just do TAVI one day, mitral the other day?
Well, preferably TAVI at the same day. So we do the same procedures at the same moment. But we also mix up with TAVI, and 2 weeks ago we did 4 TAVIs, a mitral clip and a paravalvular closure. So it's a mix-up of procedures. But preferably the same procedure continuously, because then the whole team is dedicated for this procedure.
So one final question, which is, again, a bit provocative and from our audience, which is that you've shown this very beautifully with the SAPIEN 3 valve. Would you be able to do this with other commercially available technologies? And if not, why not?
Well, we did 6 core valves in a row, and also finished at 430. But it's slightly longer than we do with the SAPIEN. I think the checkup after implanting the valve takes a little bit more time with the core valves. So whether there's paravalvular leakage, do we have to add something afterwards? Do we have to postulate, yes or no? And the exchange of sheets if you have to postulate.
Some people are managing the temporary transvenous pacemakers outside of the coronary care unit. Are you able to do that, or are those patients in the coronary care unit and in bedbound for the time you leave the pacemaker in?
Well, in our ward, they can still stay with the temporary pacemaker.
They can.
It's not necessary to stay in the coronary care unit.
As a surgery ward, we are used with temporary wires, not for the groin, but they're used to handle all the different rhythms. So.
Well, thank you again, and maybe we conclude this remarkable collaboration with a remark which comes from the audience, and just want to feed back to you, impressive collaboration, beautiful to see. So congratulations for this outstanding teamwork. Now it's my pleasure to introduce Marty Leon, who will provide us with some concluding remarks, and I think this is also a privilege, as we all appreciate the tremendous contribution Marty Leon has done to the field in introducing technology, in introducing transcatheter aortic valve implantation, and providing the most solid level of evidence. Marty?
Stefan, thank you very much. I want to congratulate the faculty. This was truly a superb symposium. It had drama, it was very provocative, we had predictions, and I think you've seen just a sample of some of the exciting new technology that will guide us in the future. I'm going to keep this very brief because you have an evening ahead of you. First, I would say that you heard from Bernard that there are some interesting epidemiology forecasts which indicate that there is global growth in patients with valvular heart disease that really parallels the global aging that we see and continued underdiagnosis and undertreatment, in part due to lack of disease awareness. And this is something that in the future, from an epidemiologic standpoint, we need to address, not just to treat the patients presented to us, but to identify the patients that have significant disease who could benefit. I think this should be one of the focuses in the future. You've heard that TAVI technology advances have contributed importantly to improved clinical outcomes. Stefan certainly emphasized this at the very beginning. You've seen so much technology that has impacted the way we practice TAVI. You've seen 7 cases done in a period of 8 hours in one laboratory, which is really a striking demonstration of how quickly we've moved with this technology. You've also heard what I would describe as the structural equivalent of Patrick's rosy prophecy, which is to say that perhaps that open surgery will be performed certainly less frequently and perhaps infrequently in the future over the next 5 years. And I would encourage our surgical colleagues to embrace that notion and to participate in this revolution, as you saw from our colleagues in Leiden, because this is the way that we work together as a heart team. We learn from each other. A core theme in TAVI growth has been this overwhelming supportive evidence that's been generated in meaningful clinical trials. This allows us not to confront our colleagues, but to simply demonstrate some of the strengths and weaknesses of these new technologies. It helps us to accelerate the guideline advancement process. So you've heard about current, ongoing, and planned new studies in low-risk patients, asymptomatic patients with severe aortic stenosis, moderate aortic stenosis with heart failure and reduced ejection fraction, aortic and mitral valve-in-valve, bicuspid aortic valves are being studied, and certainly minimalist procedural strategies as well. We've also learned that the value of innovation, especially these high-cost novel therapies, may be difficult to determine, and to communicate that message with our regulators and our health economists and the people who control reimbursement in each of the countries that we work in can be problematic and can be difficult. But it's clear that direct and persistent input from the clinicians to the regulators, in addition to the evidence generated from clinical trials demonstrating clinical outcome benefits, as well as cost effectiveness data, is essential in this process. And we've learned that you have to be persistent. It's not going to happen overnight, and that the physicians have to participate in that process, not be passive and not be bystanders. You've seen this remarkable 7-case display of modern-era TAVI, how much this requires not just a coordinated, but truly an orchestrated heart team effort. What you didn't see was the amount of preparation that went into each one of these cases, even before the patients came into the cath lab. That to develop efficient hospital clinical care pathways allows treatment of large numbers of patients per day without sacrificing optimal clinical outcomes and with rapid home discharge in appropriate patients. So we don't have to sacrifice quality to be able to do quantity if we can improve our efficiency and have a well-orchestrated system, which will be different in different environments. And finally, we've seen that the Edwards Lifesciences commitment to advanced valve programs is indeed comprehensive, including some futuristic strategies for new surgical aortic valves, borrowing from some of the principles of the transcatheter valves, which I think is very important. New transcatheter aortic valves you've seen, both self-expanding and balloon expandable. dry leaflet technologies, and multiple transcatheter approaches for atrioventricular valve disease, mitral and tricuspid, this concept of a customized or toolbox approach. Clearly, this is a diverse and robust technology pipeline. So what we've tried to demonstrate to you is that transcatheter therapy of valvular heart disease is alive and well. It is progressing at a breakneck pace. We've seen some breakthrough technologies in the aortic space, which we expect to continue. And we also expect to see, if not similar, certainly continued and positive advances in the other valve spaces over the next many years. So with that, I'm going to end the session, but I have two housekeeping details. First, our host for this symposium, Edwards Lifesciences, would like to invite you to attend a reception, which will be in a lounge outside this auditorium. So please join us. And finally, our colleagues at PCR implore you to upload and to open the PCR app. Go to the satisfaction survey in the general menu to answer the questions so that we get good feedback on whether or not these sessions are meaningful to you. Thank you very much.